Good afternoon, my name is Leclerc, and I'm an assistant professor of otolaryngology at the University of Montreal. I first want to thank the Fall Voice Committee for giving me the opportunity to present our work on laryngeal EMG, and I also want to thank my collaborators. One of the authors has this disclosure, and the funding with which we paid participants during this study came from the Pittsburgh Eye and Ear Foundation and the UCSF Merson Chair in Laryngology. We all know that laryngeal EMG is commonly used for the understanding of neurogenic causes of abnormal vocal fold motion. Typically, qualitative laryngeal EMG analysis includes motor unit recruitment, abnormal spontaneous activity, and motor unit configuration, which include polyphasic potentials. In addition to standard LEMG techniques, quantitative studies, which include laryngeal electrical synkinesis and turns, may also be used. But interpretation of laryngeal EMG data can be challenging, especially when only subtle abnormalities are seen, since minor changes could be considered within the spectrum of normal. The objective of this study was to determine the rate of abnormal laryngeal EMG findings in healthy asymptomatic adults. This data will provide a spectrum of expected laryngeal EMG findings that should be useful for clinical decision-making and research purposes. This study was conducted at the University of Pittsburgh Voice Center and at the UCSF Voice and Swallowing Center between January 2018 and April 2019. English-speaking participants of 18 years old and older without voice complaints were recruited online. Potential participants were then screened with a web-based questionnaire to determine their eligibility. Eligible participants were then contacted for an in-person appointment. Participants with a medical history that put them at risk of having laryngeal nerve abnormality were excluded. Participants were also excluded if they had allergies to one of the products used in this study, or if they had risk factors for complications during laryngeal EMG procedure. Qualifying participants completed the Voice Handicap Index 10 and underwent a flexible laryngoscopy. Participants with a VHI-10 result greater than 11 or with abnormal vocal fold movement were excluded. The laryngeal EMG was performed by a fellowship-trained laryngologist using a single concentric needle electrode. The skin was anesthetized with a vapocoolant spray, and qualitative and quantitative data were collected for the TALCA muscle complex and the CT muscle on both sides. All potentially abnormal recordings were then reviewed by a board-certified electrodiagnostic medicine physician who was blind to the age and gender of the participants. 171 people contacted the research team to participate in this study. Of these, 46 participants underwent the laryngeal EMG and 40 completed all 4 muscle evaluations. During recruitment, participants were divided equally in different age groups to ensure diversity, from 18 to 34, 35 to 49, 50 to 64, and 65 years old and older. For the qualitative results, out of 88 TALCA muscle complex tested, 2% had 2 to 3 discrete polyphasic potential, and one of those participants also had a slightly reduced motor unit recruitment pattern. Out of 90 CT muscle tested, there was no abnormal qualitative findings. None of the evaluations showed fibrillation or sharp waves. Regarding the presence of one discrete polyphasic potential, these findings were not included in the total number of abnormal qualitative results, since it is considered a minor abnormality and not clinically significant. None of the participants had bilateral abnormal qualitative findings, and there was no significant correlation with gender or age. When testing for quantitative abnormalities, we found that 8 muscles out of 86 had evidence of synkinesis, and only 1 participant had bilateral synkinesis. Turns data were available for 56 muscles, and turn per second under 400 were not noted in 5.4% of the muscle tested. Again, there was no significant correlation with gender or age. This is the first study to describe qualitative and quantitative LEMG findings in healthy adults who did not have a contralateral vocal fold paralysis. Surprisingly, in our population, there was no correlation between laryngeal EMG abnormalities and age. We expected an increased number of abnormal findings with aging, similar to limb muscles, but our results showed no correlation between age and abnormal findings. We reported a 9.3% prevalence for abnormal synkinesis. Considering that studies on vocal fold paralysis have found an incidence of synkinesis between 8 and 10%, our findings may reflect exuberant motor unit activity in some normal individuals. In this study, none of the participants who had synkinesis had abnormal qualitative findings. With that in mind, we propose that the presence of both abnormal qualitative findings and synkinesis findings in the same muscle suggests a true abnormal neurogenic process, whereas synkinesis findings without the abnormal qualitative findings could be a normal variant. In our population, the prevalence of abnormal turns per second was 5.4%. However, only one subject had what we consider true abnormal turns, while the others were only slightly low, both at 360 turns per second. Slightly low turns can be explained by pain inhibition. This is when a participant may have voluntary reduced turns because of pain. In conclusion, the prevalence of abnormal qualitative and quantitative findings was low in our group of asymptomatic healthy adults across the age spectrum. We found a 2.2% prevalence of qualitative abnormalities, a 9.3% prevalence of synkinesis, and a 5.4% prevalence of abnormal turns per second. There was also no correlation between laryngeal EMG findings and age. We believe that this study will strengthen the understanding of normal laryngeal EMG variants and the application of laryngeal EMG in patients with neurogenic dysphonia. Thank you.